Hi everyone, I'm Wendy Magee from Temple University in Philadelphia, USA. I have made this short video for you about the psychometrics of music therapy assessment. Thanks very much for coming online and having a look at this. So I'm going to talk you through some PowerPoint slides. Just to say, I just want to acknowledge that this is a presentation that represents the work of the International Music Therapy Assessment Consortium, IMTAC. And I'm going to be talking to you about the psychometrics of music therapy assessment, specifically what is psychometrics, and also why are psychometrics important for assessment tools and other types of clinical measures. I just want to point out that I'm going to be using the terms assessment and measure a little bit interchangeably in this presentation. So, what are psychometrics? Well, psychometrics concern the design, the administration, and the interpretation of quantitative tests for measuring both behavioral and psychological outcomes. So, we think about psychometrics when we're actually wanting to measure an outcome of interest. That might be physical movement, it might be mood, it might be something about music cognition. And psychometrics is important when we're actually thinking about both designing the whole assessment of what we're doing, administering it, but then also making sense of the results and interpreting the results. So the main questions when we're thinking about the psychometrics of an assessment are, does the assessment have reliability and does it have validity? And these are the two really important psychometric properties when we're using an assessment or a measure of a different sort. So first of all, let's think about reliability. There are two different types of reliability that we think about mainly in terms of psychometrics of assessments. First of all, there's inter-rater reliability. Inter-rater, between-rater reliability. And the question here is, do different raters use the measure in the same way? Do different raters come up with the same results with the same measure? So that's inter-rater reliability. And our second main question here is test-retest reliability. And that means, does the measure or the assessment perform the same way on different occasions? That is, if I use the assessment on Monday and then I do the assessment again the next day on Tuesday with the same patient, am I actually using that assessment the same way? And do I come up with similar sorts of results, given that we wouldn't expect a person to change dramatically over the space of one day? Obviously, people change and we want to be able to capture that in assessments, but we want to make sure that it's the change we are seeing is because the person is changing and not because the assessment doesn't have test-retest reliability. So, a measure's reliability is often reported in terms of correlations and correlational statistics. Correlations basically report the degree of agreement between two or more raters or between two or more events. So, for example, when you see that an assessment has a reliability, an inter-rater reliability of 0.8 or above, you can be sure that it has a very strong relationship of agreement between two different raters, in the case of inter-rater reliability, or between two different occasions, two different clinical sessions, in the case of test-retest reliability. Just to try and explain this in a different way, I've got this diagram here. If we had two raters assessing the same person at the same time, we would want to see that there were common observations and common results made or formulated, common assessment outcomes formulated by those two different raters. We would want to see that at least 80% of their assessment agreed with each other. So here we have two separate people, two separate entities, but we want to see like an 81% shared common outcome from this assessment. And that's what it means by saying that an assessment has 0.8 or above of correlational agreement. And here we have the different categories going from 0.6 to 7.9. Correlation is a strong relationship. 0.4 and above to 0.59 is a moderate relationship, and so on. And we can see that if we are actually doing an assessment, if we are using an assessment where the inter-rater reliability is less than 0.19, it's really a very weak measure in terms of its reliability. So ideally, we would be using measures that are more up here. They have at least 0.8 reliability for inter-rater reliability and also for test-retest reliability. Now, validity is something that's a little bit different. Validity is really asking, does an assessment assess what it is meant to assess? Does a measure what it is meant to be measuring? Okay, so here are some important types of validity for assessment measures. First of all, population validity. Is the assessment valid for the population with whom you are using it? If you are working with adults, then you want to find a measure that's suitable for adults. But if you're working with children, you want to make sure that you are using a measure that is validated for children, not just using an adult validated an adult measure that isn't validated for children. Similarly, if you're using a measure that's valid for psychiatric populations, you need to question whether it would be appropriate for brain-injured populations. So population validity concerns whether the measure is appropriate developmentally. Has it been tested for your developmental population, children versus adolescents versus adults? And also, is it appropriate for your particular population, your particular clinical population? The second type of validity you might think about is construct validity. And this talks about, does the assessment actually assess the central construct that you are looking at? So a way of explaining this in a little bit more detail is, the concepts of mood, self-esteem, well-being, emotional states, we tend to, in clinical work, use those a little bit interchangeably. However, when you're talking about assessment measures or measures more broadly, these are quite specific psychological constructs, and you want to make sure that the measure you are using actually is valid for that particular construct. So, for example, if you're interested in mood, in how music therapy might change the mood of your population, you wouldn't be choosing a self-esteem scale because that's quite different. Similarly, if you're looking at well-being, mood and self-esteem might be parts of those, but they're not the central construct of well-being. So you would be looking to find an assessment that actually measures well-being. So all of this is to do with construct validity. Does the assessment actually assess the central construct of interest? Content validity. And here we're talking about the items that make up an assessment. As you know, an assessment is rarely just one question. It's normally a number of questions. So all the items, all the different questions that form the assessment, content validity examines how all of these items are related and how well they are related to each other. For example, let's come back to the example of mood. If we were looking at a mood assessment, we might be interested in different types of moods, but we would want to make sure that all the different factors are taken into consideration there. So we wouldn't want just an assessment that looks at happy, contented, pleasurable. or positive mood states. We would want to have a mix of negative and positive mood states to make sure that all the factors are relevant. And we also wouldn't want to see a question in there that's actually got more to do about self-esteem. So again, content validity has a look at how well the items are related to each other and how well those items actually form all the factors that need to be considered in an assessment on that construct. And lastly, this is just a very brief introduction to validity. Lastly, concurrent validity. How does the assessment perform compared to other validated measures for the same construct? And here I'm going to use an example of the measure that I've been involved with, the assessment, the MATADOC, which is actually an assessment of awareness. So when we tested the MATADOC in the initial research project, we used a validated, standardized measure of awareness, the SMART, and we took concurrent data, collected concurrent data with the same patients, and we looked at how the MATADOC outcomes compared to the SMART outcomes. And that's an example of looking at concurrent validity. So just to say that there are many different types of validity, and you need to make sure that your measure, the assessment you're using, certainly is appropriate for the population with whom you're working. Okay, the implications for practice. Well, we've talked a little bit already about it's important to use an assessment or measure that's valid for your population. Because if you're using a measure which isn't valid for your population, then the results really don't hold any weight at all. So that's the first thing. Is it meant for your particular populations, thinking about age and also the clinical diagnosis? Also, using a measure that has been standardized for reliability and validity gives its results much greater weight. And this is particularly important for interdisciplinary practice, but also where you might be using your assessment in terms of mandatory reporting and also reporting to external agencies, so such as funders or legal, in the case of legal cases. Measures also need to be validated in the language in which you're working. So I have a lot of people ask me whether they can translate the MATADOC into their language so they can use it. And by all means, you can do that, but it's no longer valid because it hasn't been validated in that language. So for example, taking an English-based measure, translating it into Spanish, it means you can use it, but it actually isn't valid in that language. So that's just something to keep in mind. Sometimes, though, a non-validated measure can be better than no measure. I would say that. And the last really important point is that changing an existing standardized measure means that the results you come up with cannot be trusted. So if you take items out because you don't think they're relevant, or if you put extra items in because you think they'll enhance the measure, that actually changes its reliability and its validity. So it's really important not to omit parts of existing measures or to change the method of administering the assessment. For example, if you are looking at a measure which is very specifically around improvised music, you might want to question delivering a completely different protocol where you are only using song-based interventions. So these are just very briefly some examples of standardized music therapy assessments. And I just did a very quick literature search to find these, but just to give you some ideas of the range of populations, we've got the assessment of parent-child interaction, the Beach Brook music therapy instrument, the interest in music, music attentive screening assessment revised, the music therapy assessment tool for advanced Huntington's disease, and the music therapy assessment tool for awareness with disorders of consciousness, music therapy session assessment scale, and the residual music skills test. So these are all some examples of assessments that you will find, and some of these certainly appear on our IMTAC database. So just to summarize, a robust assessment is one that's been tested for reliability and validity. That is, it has psychometric strength. An assessment's psychometric properties tells us about the strength of its performance, how it works with different raters, how it works on different occasions, and how it works measuring a specific construct. Using an assessment that is reliable and valid for your clinical work will carry greater weight with other disciplines and external agencies. Thank you.